All right, guys, this is the final lecture of the urinary system chapter, and this is going to be on chronic kidney disease and all the sequela that kind of follows in with this. So, with chronic kidney disease, as opposed to when we were looking at acute kidney disease or acute kidney injury, this one takes many, many years to develop. So, this is that gradual decrease in kidney function. And because we're dealing with a destruction of nephrons, this is completely irreversible. So again, most commonly what you're going to see with chronic kidney disease is you're going to see that it's caused by diabetic nephropathy, so diabetes. It could be hypertension induced, like with nephrosclerosis. It can be glomerulonephritis if we're dealing with like a chronic glomerulonephritis, so an individual who keeps getting repeated infections that have led to that. And then autoimmune diseases such as, lupus, there's scleroderma, there's other types of autoimmune diseases that could potentially lead to chronic kidney failure. But most of what we're seeing is going to be either diabetic induced or cardiac induced with hypertension and atherosclerosis. So pathophysiology, chronic kidney disease, this is where a large proportion of nephrons have been damaged. And again, this doesn't just happen overnight. This takes many, many years to develop in our patients. So renal insufficiency, that's when we're dealing with 75% of our nephrons that are lost, whereas in-stage renal failure, we're looking at 90% of nephrons lost. And when you have only 10% of your nephrons that are functioning, you experience uremia, where you have urea that just stays in the blood, and this becomes a problem because it affects all of our body systems. So signs and symptoms of chronic kidney disease, you have to kind of think about what the kidneys do, and I talked about this in a previous lecture. But the kidneys are responsible for fluid balance, for example. So, when they're not functioning, we had an accumulation of fluid everywhere. They're responsible for keeping, not only the fluid in check, but they're also responsible for electrolytes. So, again, you're going to see electrolyte imbalances, and some of them can be quite deadly for our patients. We have waste products that are retained because we're not able to excrete them. The kidneys are responsible for acting as the buffer with bicarbonate when we're looking at acid-base imbalances. So you're going to see not so much respiratory imbalances here, but with kidney disease, you'll see metabolic imbalances and more commonly metabolic acidosis. And we have to think about the kidneys are responsible for producing erythropoietin, which is essential for red blood cell production. And so a lack of erythropoietin means that our patients also have anemia type issues as well. So this is from your book. So this just kind of shows you the symptoms of chronic kidney disease. And as you can see, every single body system is going to be affected. So if we're looking, I'll go from the top and I'll work my way down. Neurologically, we're looking at fatigue, depression, headache, confusion, seizures, and coma. And part of that is because of that circulating nitrogenous waste or that circulating urea. It settles into the brain, and you will a lot of times see a lot of neurologic deficits, and sometimes your patients will even present almost with stroke-like symptoms. Okay. For the mouth or the oral cavity, we're looking at stomatitis, so inflammation of those mucous membranes in there. And a lot of times your patients with chronic kidney disease will talk about a bad taste in their mouth, and sometimes they'll even talk about it being like a metallic taste that they have all the time. So it makes it, not palatable to eat. If you always have a bad taste in your mouth, that a lot of times they don't feel like they can eat. Cardiovascular wise, we're looking at hypertension, heart failure, potential for dysrhythmias because of our potassium imbalance. Respiratory system, we're looking at fluid overload, so pulmonary edema, pulmonary effusions, dyspnea for trying to overcome the fluid production. GI system, we're looking at anorexia, nausea, vomiting, gastrointestinal bleeding, ulcers. Renal system, we've already talked about anemia. And depending on what stage we're looking at, your patients may have oliguria where they have little output, or they'll have absolutely no output whatsoever. So it's important to ask your patients that are in end-stage renal disease, do they even make urine? And that's a viable question to ask them. Skin-wise, they'll have very dry, pruritic skin. They're prone to bruising. Sometimes the skin will have a yellowish tint to it. And they'll also develop this thing called uremic frost. So remember, you have circulating urea through the body and it's got to come out somewhere. And so sometimes your individuals with kidney disease will develop this iridescent looking frost on their skin, and that's that urea trying to come out through the skin. Reproductive system wise, we're looking at sexual dysfunction, infertility issues. Musculoskeletal system, we're looking at prone to fractures, and again, part of that could be an electrolyte imbalance or just poor nutrition in general. And then fluid volume, very, very edematous patients. So as you can see, there is not a single body system that is not affected by chronic kidney disease. So therapeutic interventions, we're looking at a diet that is high calorie, low protein. So I think I told you guys that, anytime we're looking at kidney dysfunction, we look at low protein for diet, unless we have a dialysis patient. Okay, if we have a dialysis patient, then they will give them some protein because they're going to pull so much out of the body that you're going to have to put some protein back in so that they can have adequate healing. Definitely low sodium, low potassium, low phosphorus. That's a big one. Okay. So in fact, you got to remove anything dairy product wise from their lunch trays, for example, because of the phosphorus that's in it. If you know anything about electrolytes, you'll know that calcium and phosphorus are inversely proportional. So when one is up, the other one is down. So if we have to have a low phosphorus diet, we will have increased calcium that we need to give them. And I know I told you about milk products. I know milk has a lot of calcium, but again, it also has a lot of phosphorus in it. Okay. So a lot of times instead of giving them dairy products, we will give them just calcium supplements. Okay. And then vitamins. We give a lot of vitamins, multivitamins. We will give them a medication called Renagel, which is a type of vitamin that actually helps keep the phosphorus levels down in your patients. And we're going to be on a very, very strict fluid restriction. Okay, we've got a patient who doesn't get rid of fluid very easily, so we want to make sure we restrict their fluid as best as we can. Medications, I've already kind of talked about some of these, but we're going to do diuretics. Even if you have a patient that does not make urine, okay, they can diurese through their skin. Okay, so we'll give diuretics. We'll give antihypertensives to make sure that we keep their blood pressure in check. Phosphate binders, that's that Renagel that I was just talking about. We'll do vitamin D and calcium supplements. And we will also have to constantly be on high alert of what our potassium levels are. So Kayexalate is a common medication that we'll give them to lower potassium. But if we're in an immediate need where we have a patient who has an extremely high, very dangerous potassium level, we can give insulin and dextrose, and that can actually drive the insulin back, or I'm sorry, drive the potassium back into the cell until the patient can be dialyzed. The only definitive way to decrease that potassium level is to dialyze them, okay? But we can do things like Kayexalate, insulin, and D50 to make sure that we keep that potassium in check. For dialysis, you're going to dialyze the patient when there's symptoms of fluid overload. So most of your chronic kidney disease patients they're on a schedule of about 3 days a week. But as the progression continues and more nephrons are damaged, you may see these individuals requiring dialysis more frequently than that. So in addition to their 3 days a week, you may notice that when they have symptoms of fluid overload, or they have high potassium levels, or they're starting to show neurologic signs, they may get an additional dialysis session on top of their regularly scheduled ones. So if you're not familiar with hemodialysis, this is a picture of hemodialysis here. So you can see the patient is hooked up to the machine, and basically what it does is it removes all the harmful particles from the patient's bloodstream. They filter it through a machine, and then they put it back into their patient. But then they also have to remove some of the excess fluid as well. Okay, so it's a process in which the patient has excess fluid removed, which actually alleviates some of their fluid overload symptoms, and it also cleans out the blood to remove the particles that are dangerous. And then here's an actual patient going through hemodialysis. And I think it's important to note that when you're dealing with dialysis, this individual is hooked up to that machine 3 to 4 hours a day when they're in dialysis. So their quality of life is very, very impacted. And a lot of individuals get very, very frustrated with the fact that they have to donate so much of their time just to stay alive. And so again, it is a source of frustration for individuals when they have chronic kidney disease. So for hemodialysis, basically what is happening is the machine acts as an artificial kidney, and it removes waste products and excess water from the blood. Now, to do this, you have to have some kind of vascular access. So they can have a temporary one, which would be like a central venous access device, like a triple lumen, that they could put through a central vein, most likely your subclavian vein. And they can use that until the patient gets a permanent one, okay? And so your permanent vascular access will either be something called an AV fistula or an AV graft, okay? And that's what we want. We want that permanent vascular access because it's a bigger site, and it actually will help the patient have better vascular access to remove those impurities from the blood easier. Now, the vascular access, what you have to remember is this is a line. This is a line that you've really got to make sure that you take very, very good care of. And so it requires assessment. So the thing that we usually say for your vascular devices is you feel the thrill, okay? So that means that you palpate it, and it feels like turbulent fluid rushing under your fingers. And then you auscultate the bruit. So you'll take your stethoscope using the diaphragm side, and you will auscultate that vascular, and it should sound machine-like. It should sound like a turbine if you have a patent vascular access, okay? We also protect these at all costs, which means that we put this patient on a limb alert. So no lab sticks, no blood pressure cuffs on a side that has a dialysis catheter. Post-operatively, you want to make sure that you do neurovascular checks. So we're going to check for pain, paralysis, pulselessness, paresthesias, poikilothermia, okay? And then we want to elevate the extremity to help facilitate some of that drainage out of the arm. So here's a picture which you can see what hemodialysis access sites look like. So the top one there, that's where they're going to anastomose the artery and the vein together, and that would be their access site there. The other one, they've kind of created a connection between the two to connect them by way of a graft. Okay, so you've got your fistula, you've got your graft, and this is kind of the difference between the two and how they would access them. Now, there also is peritoneal dialysis. So the benefit of peritoneal dialysis over hemodialysis is that this is a continuous dialysis done by the patient in the comfort of their own home. Peritoneal membrane is in the abdomen. It's a semi-permeable membrane, and it has a way of removing the excess waste and the fluids from the blood, just like we would with hemodialysis, except it's done through a peritoneal catheter in the abdomen. It has basically an exchange process in which the individual will they'll fill the peritoneal catheter with the diacylate solution, and then it has a dwell time where it will sit in the peritoneal space for hours. And so I've seen a lot of individuals where they'll fill it right before bed, and then they'll let it dwell for several hours overnight, and then they'll get up and then they'll drain it off in the morning. Now, peritoneal dialysis, while that does sound nice that it could be done in the comfort of their own home, these individuals have to do this every single day. Okay, whereas hemodialysis a lot of times is 3 days a week. So peritoneal dialysis, you also have to make sure that your patient is compliant and that they're going to do this every single day. And so here's a picture of what peritoneal dialysis looks like. So you kind of hang it to gravity. You can see where the fluid is going in. You can see the catheter in that peritoneal space. And then after the dwell time is over, then the fluid is going to come back out in the bag, and you just hang it lower so that gravity will fill it back into the bag. Now, I do want to say, because I can't go back on my slide now, the worst complication of peritoneal dialysis is something called peritonitis. So you could get a rupture of the peritoneal cavity, and the way that you would know if that was happening is your patient would have what they call a board-like rigid abdomen. Okay, so peritoneal dialysis is not without, its own complications. So it is something that the doctor needs to make sure that they check with the patient and see what the patient is a better candidate for. Are they better candidates for hemodialysis, or are they a better candidate for peritoneal dialysis? But either way, any patient that is on dialysis, the only cure for chronic renal disease is a kidney transplant. And so the way that this is accomplished is this is done either through living related donors or through a cadaver donor. And whichever option the individual goes with, they will be on anti-rejection drugs for the rest of their life. And so it's something that, when we do get the kidney transplant, it's not over and done with. They have a lifelong journey of making sure that their body doesn't reject the transplanted kidney. So one thing that I didn't know when I started working as a nurse is I didn't realize that when they did a kidney transplant, they actually leave the diseased kidneys in place. And so you can actually see where they're still attached up there at the top of the tree. And then the transplanted kidney is actually done on the lower side of the abdomen. Okay, so they actually do it on the anterior side of the body. So the patient will have 2 diseased kidneys and 1 transplanted kidney. And you can see where they've anastomosed it to the aortic branch there, so that it would function just like any other kidney. But yeah, there's 3 kidneys in the body when you have somebody that gets a kidney transplant. Nursing diagnosis for your patient with kidney transplant, we're looking at excess fluid volume, impaired skin integrity, activity intolerance, risk for injury, definitely high risk for infection, imbalanced nutrition, less than body requirements, all excellent candidates for a kidney transplant patient. Nursing care, we're looking at specific interventions for each one of them. So for the excess fluid volume, we're going to monitor their weight. You remember, the best indicator of fluid status in the body is the patient's daily weight. We're going to have accurate intake and output. We will do fluid restriction, and we're going to monitor for any signs of fluid retention. So again, we'll be assessing them for pitting edema. We'll be assessing them for weight gain. Electrolyte imbalances, we'll draw labs, we'll monitor those sodium levels, we'll look at the potassium levels in particularly, and we will do dietary restrictions based on whatever our electrolyte imbalances are. And because we're worried about potassium all the time, we're going to monitor our patient for cardiac dysrhythmia. So we want to make sure that they're on the cardiac monitor so we can catch them in time. For waste products, we make sure we provide adequate oral care, meticulous skin care. We protect the skin at all costs. We use water-based lotions, not alcohol-based ones, because alcohol-based ones continue to dry the skin. And we want to protect the patient from injury. And for impaired hematologic function, so remember, we're dealing with an individual with a reduced production of erythropoietin. So again, we're dealing with anemia type issues or an individual who doesn't heal very well. So we want to protect from injury and or infection. All right, and that is going to wrap up chronic kidney disease.